Hi, my name is Isabel, and in this video, I will be interviewing my mom, who is a primary care provider, who has two patients with LGMD. Before we dive into the interview, I want to give you guys a brief overview of how LGMD differs from DMD. So LGMD, standing for limb-girdle muscular dystrophy, is a type of muscular dystrophy that is autosomal recessive. So this means that men and women can have LGMD, whereas in DMD, since it's an X-linked genetic disease, only men can have it. In some rare cases, women can, but for the majority, only men do. Additionally, the age of onset for LGMD is between 20 to 30 years of age, rather than in early childhood for DMD, and the life expectancy is much longer than DMD, as it's generally within a normal range for patients with LGMD due to the heart and breathing muscles usually not being affected. Some forms of LGMD progress rapidly, which causes for serious muscle damage and the loss of the ability to walk, while others advance more slowly over many years and cause for minimal disability. Additionally, unlike DMD with dystrophin being affected, LGMD has a variety of types with different proteins affected, but the one that we'll be focusing on is LGMD type 2I, which is caused by a mutation in the FKRP gene. And if you don't know what the FKRP gene is, this protein is involved in a process called glycosylation. And through this process, it causes for the normal function of alpha-dystroglycan. So without glycosylation happening, due to the mutation in the FKRP gene, alpha-dystroglycan will not be normally functioning and it won't be able to link the muscle cell to the extracellular matrix, which causes for muscle weakness and muscle damage that we see in LGMD patients with this type. So now that you know a little more of the background about LGMD and its relation and differences from DMD, let's dive into the interview with my mom, who had two patients with LGMD, but she'll be focusing more on one in particular.
RIEKE-WEY. I'm a primary care provider, so in internal medicine, and I work at Overlake Medical Clinics in Bellevue, Washington. So the one that I'm more familiar with, she is about, let's see, almost like 49, and I've known her since 1999. So right now she is, pretty limited. She's completely so she's wheelchair bound. She's completely dependent on her ADLs, activities of daily living, with others. So she has two daughters who are in high school now. So she needs someone to be with her at night, majority of the time, to help her change, go to the bathroom, position transfers. But I mean, she works as a teacher, actually. So she has a car that allows her to mainly use her hands to drive. But she's pretty, I mean, she's functioning, but pretty debilitated. So her history was, and this is before I met her, but when she was a child, she was, not a great athlete. So she said that she was everyone called her like a slow runner. So when she was a child, kind of in middle school, high school, she underwent a pretty extensive evaluation at Children's Hospital down here, which is the main kind of pediatric hospital. And she had really elevated liver functions, and they thought she had some kind of liver disease. But it turned out later that was just part of the manifestation of the limb-girdle muscular dystrophy. She was diagnosed in 1999, so at that point she was 25. And the diagnosis was polymyositis, which is kind of a rheumatological condition that they felt she had like painful muscles and weak muscles, and her muscle enzymes, which is like a CK, was it was pretty high, like 1,000, 2,000, which is, normal being like, maybe less than 100. So the diagnosis then was polymyositis. So she was treated, with steroids, IV immunoglobulins, immunosuppressants like methotrexate. She wasn't getting better, so they got a second opinion and at the UW rheumatology. And then she wasn't officially diagnosed. So this is 2002. Treated for polymyositis until 2012 when she was diagnosed officially with limb-girdle muscular dystrophy. So she was treated for an inaccurate diagnosis for a long time, not getting better. And so she wasn't diagnosed until she was 38. What's also interesting with this, so they finally diagnosed her with genetic testing. So then they found that she had she was homozygote mutation for the FKRP. You may know that more than I do, Fukintin related protein. So it was recessive, autosomal recessive. So she got one from each parent, which is kind of rare to get that. And before she was diagnosed in 2011, she actually had like a slow heart rate and rapid rate. So she had like a tachycardia and a bradycardia. So she actually had a pacemaker put in. So now looking back, why would someone so young have a pacemaker, right? It's part of the manifestation of the muscular dystrophy, which before she was diagnosed. So kind of interesting. And she also, before that, was diagnosed with sleep apnea. So it can also manifest with pulmonary manifestations. And so kind of looking back in retrospect, right, we realized, wow, so weak proximal limb weakness, upper and lower extremities, kind of heart issues, lung issues, and then it kind of makes sense, like it's muscular dystrophy, because polymyositis in someone so young too, it's somewhat unusual for her to just kind of have progressive weakness and not be able to move, and no response to the treatment for polymyositis. So it's important to have that in your differential, but yeah, we don't see that often. So. Wouldn't have needed she had 10 years of wrong treatment with IV intravenous immunoglobulins, methotrexate, steroids. When you're immunosuppressed, you have a lot more risk for infection. So, during those 10 years, she was at risk for other illnesses. So she had, 10 years of treatment that she didn't need. It wouldn't have changed the progression of her disease. But then she would have realized, earlier that she had this disease that's progressive and kind of made life changes, like, in terms of like, like adapting things in her home for, as she progressed, so unfortunately she's she's divorced, 2 kids. Her kids have lived with her knowing that her mom is, needs their assistance. So they're used to caring for her mom, which is hard think about it, like a she's, 9, 13, taking care of their mom, so. I think we should have to be more aware of just broadening the differential diagnosis, particularly in women, because both my patients were female. And a lot of times we just don't think of that, I would say. I think we tend to think more of rheumatological conditions than like genetic conditions, So it's just kind of just being more aware. And fortunately, she's an area where we have, like a really good, kind of genetics and pediatric facility where they see these diseases, right? So a lot of times in other areas, you may not see these. So
as we can see from that interview with my mom, her patient lived with a misdiagnosis for 10 years, which was probably really frustrating when she found out her real diagnosis of LGMD, as if she knew earlier, she could have made more lifestyle adjustments, and her kids could have as well. So this interview made me think about how there are many other women out there who have been misdiagnosed and who are currently misdiagnosed, when in actuality, they could have a genetic disease such as LGMD. They could be in areas where these types of diseases aren't seen frequently, because luckily, my mom's patient was in an area with established muscular dystrophy research and treatments, so they eventually found a correct diagnosis. But people who are in areas where these types of diseases aren't seen very often could hinder their opportunity to get correctly diagnosed. So it's so important that in our healthcare field, especially when treating women, because we don't always think women will have genetic diseases, to be aware that LGMD and other genetic diseases could be an option for diagnoses, and we can't rule out them when treating patients, and especially when we see all of the symptoms that align with a muscular dystrophy diagnosis.